We'll get going again here on cardiac arrest part 2. Most of this has to do with post-resuscitative care. There's a couple of things I want to go into in a lot of detail, and some that I think we can kind of just understand what some of the papers say and their limitations. So the first one here is what I call a we did it, we like it kind of study, where people publish, here's what we do in our protocol, and by gosh, we think it's better than what we used to do. Okay, so that's fine, but it doesn't tell you much other than the fact that now people are doing a little better than they used to. And the first one here is like this, and they say we did a lot more of other things after the patient got resuscitated. So we can kind of learn other people are doing these things, but it doesn't really give a comparison as to what makes the difference. Because again, as I mentioned, and I'm going to say it time and time again, are the two groups equal but for the intervention? And you never know that. The other thing is that, as I've mentioned also, this idea of giving up and saying, you know, a no code after a while. It may be that once you think you're doing things well, you can encourage the family, you know, like, no, don't give up. I've seen people who look this bad at day one, and they made it, and they're okay, and so let's not give up. And maybe that's true. I'm not saying it's not true, but you might then, of course, have more survivors in your group. But anyway, that's all that said is we did it, we liked it. So the next issue is if we think most cardiac arrests are due to acute myocardial infarction, and acute myocardial infarction is usually due to a coronary thrombosis, how about giving them thrombolytics? Maybe we should be doing that. So that's what a lot of these papers look at, and they do it in two different ways. One is they give it to them during the cardiac arrest. They say, well, better give it now, that way the artery will open, and for that reason they'll come back. Or some of them do it after they get them back and say, well, it's probably a heart attack, we ought to just give it to them right now. And so that's what these things look at, and most of these are registry data. So in registry data, people get to treat patients any way they think they should. So some people will get thrombolytics and some people won't get thrombolytics. And in 53 here, they look back at people who got the thrombolytics, and some of those did better than the ones who didn't. So again, why might those two groups be different? Well, when you think about it, first of all, they had an average amount of CPR for 30 minutes. Who here does CPR for 30 minutes when it doesn't work? I don't know. I think as you get older and older, you do CPR for less and less time, you know. So, but how might you have a case where you're in the room and working on them for 30 minutes? Because you get them back intermittently, and then you lose them, and then you get them back intermittently, and then you lose them, kind of thing. So those people, you think, boy, I think they're going to make it. Let's give them some lytics. Maybe that'll work. So maybe those two groups are different just for that reason. I don't know. And you can't tell from registry data. All you get is outcome stuff. So that was 53, did a little bit better. 54 is a meta-analysis, and they looked at a lot of subgroups. They give some ratios of how much better they did, but none of these are controlled either. 55, they did it afterwards. And if they met certain criteria, after they resuscitated them, they give them lytics, and they did it, and they liked what they did. They didn't compare it to anything. 56 was one where they gave it during. This was an interesting study. I think I've mentioned you actually can't die of cardiac arrest in Washington State, or certainly in Seattle. It looks like you can't die in Austria either. They get 48% survival to discharge from cardiac arrest. I don't know how they get these numbers. So that's one amazing thing versus 33% when they didn't do it, but it wasn't controlled. Another one there, they had 15 minutes of CPR and they didn't work. They did a before and after study, and they found it was a little bit good. A randomized study in 58. Actually, it was randomized, but the groups were not in fact balanced. You know, one of the sort of so-called gold standards of a good study is that you randomize people to it. Therefore, you think by doing that, you'll get just as many people in one group as the other who have equal amounts of disease, you know, bad diabetes and previous stroke and all that kind of stuff. But it doesn't always work that way. Sometimes, even though you randomize, you have an imbalance in the groups. And that happened here, and that probably accounted for their results. Only 2 and 1 patient, respectively, survived a hospital discharge, and the single patient who survived a discharge got placebo. So even though they randomized them, it didn't work. 60 is really the only, I think, well-done randomized controlled trial. It's actually sponsored by the maker, and it's the thrombolysis and cardiac arrest trial, and they stopped it early because they had worse outcomes. More subarachnoid hemorrhage, more death. Didn't work in that one. 61 was lytics versus PCI. It wasn't randomized, and they said it was better to give them lytics. Probably, again, that might be because that's an after, probably because you give it to them sooner. So my take on all of this is that probably during cardiac arrest, the only really good data shows it doesn't work or is worse. There's a few registry and before and after trials that maybe look better. And then for giving it afterwards, all the studies are really not of the level that would guide you in it. But I think if you have somebody, you've resuscitated them from cardiac arrest, and they meet the criteria that you would otherwise lyse them or do PCI, I don't see any reason you wouldn't do that just on that. So that's my take on that. I think the biggest issue with post-resuscitative care is therapeutic hypothermia. And I'm going to go into this in a little more detail than I do some other things, because I've got my own particular biases on it, and I want to go into some of the literature on it. So the theory here is that you resuscitate somebody from cardiac arrest, but they don't wake up. And the idea is let's cool down the brain with the idea that whatever bad goes on after you've been in cardiac arrest for the brain won't happen, and the good things that happen to restore your cerebral function will happen. I don't know where they got that idea. All the metabolic processes go down with hypothermia, and why would you expect that the good are going to outweigh the bad? I don't know why that is. I think it comes from the fact that if you do hypothermia before cardiac arrest, it's phenomenally useful. When I was a neurosurgery resident, we were studying hypothermia, and we would take a monkey and put them on the bypass pump. We'd cool down their brain to 0 degrees. We'd turn off the pump. We'd go out to lunch. We'd have lunch. We'd come back. We'd turn on the pump. We'd warm them up, and they were normal. I mean, it's unbelievable. We were measuring cerebral blood flow with, at various stages of hypothermia. It's amazing what it could do beforehand. But afterwards, it hasn't worked in anything else. You know, we did it for head injury for years till we proved it didn't work. There's a recent study on head injury in children that shows it's not only doesn't work, it's worse with that. So why would we think it works in cardiac arrest? Well, the evidence comes from 2 studies. Here's the first one. The first one here is a European study, a European multi-center trial, and they found people who weren't able to respond to verbal commands. Now, my first issue would be there's sort of coma and then there's coma, you know, afterwards. I mean, not everybody is equally out of it when they don't come back from cardiac arrest. And how were they in the beginning of things, and how long were they in arrest? All those things are different. But what they did is they gave some hypothermia, and they didn't give it to others. And they found better outcomes in the patients that got hypothermic. And I want to get this exact here. They didn't get the target temperature in 14% of the patients who were in the hypothermia group. Okay? Let's see. So the favorable neurologic outcome was by blinded monitors, and they measured that by either a survey or an exam. Okay, that's it, and that's what they said they were doing. I think they had a scale that they used, and I'm trying to get that out of this study, and I haven't highlighted it here. So they said they did better based on that neurologic outcome. It wasn't a Glasgow outcome scale. It wasn't a Glasgow coma scale. It wasn't an NINDS scale. It was just a global assessment at the end. And 14% didn't even get hypothermic, and they did better. So their conclusion was, we need to do a bigger trial. This is interesting. Let's do a bigger trial. The other thing about the trial was that they enrolled only 275 patients out of a possible 2,500 eligible. That's a really small number. Could there be, in fact, bias in those that they did where people said, well, I'm not going to register this one. I don't think it's going to work, but maybe it'll work in this one and I'll do it. So that's been one of the criticisms of that trial. So the next one is an Australian trial. They did the same thing. They took patients in cardiac arrest who came back and didn't have a return of cerebral function. They gave them hypothermia, and their outcome monitor, or how they measured outcome, was able to be discharged home versus an extended care facility. That's the neurologic exam. You know, being able to go home versus a nursing home, there's a lot of reasons for that, including your own disability, but family, pre-existing stuff, all that kind of thing. But that was their outcome measure, and they did better. Their conclusion, this is interesting, we ought to do a bigger study. That, my friends, is the world's literature on therapeutic hypothermia after cardiac arrest. You've heard it all. They are the only controlled trials that have ever been done. Both concluded, get a big trial. Both had funky endpoints. Not funky, I mean, they're okay, but they all raise good, interesting questions. But if you would design your own best trial, how would you try to decide if this stuff really works? You'd have big numbers. You would cool them down. Would you include those who didn't get cold? So should you do an intention to treat, or those that actually got cold and compare them? How would you actually compare them? Would it be an NINDS score? Would it be the difference between their premorbid NINDS score? Because some of these people probably weren't normal to begin with. So you think of all those things, and then how would you measure it? 30, 60, 90 days. You would think about doing all of those things, and none of that's been done. So I think the level of evidence here is thin, and these authors appropriately say, let's do a bigger trial. Now, in the next one here, they look at it, and they do a review of the literature, and they say there are 4 controlled trials out there. I thought, well, I've looked at all this stuff. What are those other 2 trials? So I got all these papers. One is an abstract that's never been published, and the other is actually a helmet trial that they randomized people to putting on this helmet that made their brain cold. And it was randomized, that's true. But the only outcomes they measured were venous lactates. That's it. They don't tell you how the people actually did. So, as I mentioned before, you've heard the world's literature now on randomized controlled trials. There is nothing else. Everything else is now a before and after study, an opinion piece, or a rehash of those and an opinion piece, and a policy statement. So that's it. So 66, an implicit chart review, a Swiss implicit chart review, and a before and after study. I know I've dissed before and after studies. Now let me diss implicit chart review. What is an implicit chart review? You pick up the chart and you go, oh, okay, let's see, they got them cold, they started hypothermia, well, about 2 hours later, well, that's okay. And let's see, they didn't hit the target temperature, but they got cold, that's okay. You just scan through it and see what you find. You don't know what you do, you say, well, gee, they never said when they stopped doing hypothermia. What do I do with that data piece? I don't know, I don't have it. Is that a 0 in that column? Is it a 1? You know, you don't know what to do. So it's basically, you're just looking through and saying, oh, I like this and I didn't like that. It's actually what a malpractice case is. You know, there is no standard thing. You know, if you do a real study, you have a checklist and you say, you have to measure temperature at X number of hours and you have to measure, you know, a neurologic exam at a certain point, and this is what you're going to measure. That's a structured chart review. And you say, if you don't find it, you have to grade it such and such. Implicit chart review is just sort of a sloppy way to do it. 68 historical controls. They said they liked it. 67, they used historical controls, and in their study, only 63% actually got cold. Not even everybody gets cold. Why would you think somebody might not get cold when you do this protocol? They're more awake. Yeah. Right. They're coming around. You know, it's hard to make people cold. You've got to paralyze them and intubate them in order to get them cold because people shiver and they start coming around. So I don't know if that means it. 68 is another historical controls one. 69 is a Danish study a before and after study, and they found no benefit. They said there was no long-term benefit at all. 70 was a before and after study, and the ICU mortality was exactly the same. 71, an Israeli study, and what they did here is they were basically just seeing, can we make them cold? And they gave them some cold saline. And they had a bunch of people, and they said, you bet, we can make them cold. And then when you ask, well, okay, well, how did they do? They don't tell you. Isn't that funny? You go through a whole study, and you got them cold, and you don't tell anybody what the outcomes were. Now, maybe they're just planning to write another paper. You know, that may be. They're going to then, first paper is we made it work, and the second paper, here's the outcome, or they're waiting for 90 days or something. I don't know, but a little bit strange. 72 is one that, again, it's an Austrian study, and it's a before and after study, and they looked at 97 consecutively managed patients where they put this icy guard device in them, a closed loop circuit in the inferior vena cava to make their blood cold. And then they took 940 controls. Is anybody in here, how long would it take you to find 940 patients who were resuscitated from cardiac arrest but didn't wake up? I mean, first of all, how many get resuscitated at all? Not many. And then how many of those don't come around immediately? Small. They found 941 controls. Unbelievable. And then this, of course, was not randomized. This was at the discretion of the authors. They had 30-day survival 69% in those versus 50% in the others. I just don't believe the data. I mean, I'm sure the data are in there, but there must be some enormous selection bias in going on to that. 73 is another study, how to cool off our patients. Their conclusion is we ought to do a big trial, see what happens here. The ALS task force, ALCOR, therapeutic hypothermia, the recommendation of an international task force, it's an opinion piece based on 2 studies. Which 2 studies? The 2 studies I told you about. So this is all the world's literature here. Scandinavian guidelines are there. 76 is from a guy from the University of Michigan. And what he does now is he says, well, if we did this stuff throughout the whole country, how many more patients would we save? And they take assumptions from the first 2 studies. And then they multiply it by everybody in the United States, and they come up that it'd be a huge public health impact, and we'd have, you know, all kinds of great results from it, which, of course, if you multiply these things out. And then 77 is, well, you know what? Maybe we ought to combine another drug to help take away the evil humors that happen after your brain hasn't had blood flow. And let's use coenzyme Q10. Why do that? And it's interesting, they say it's been reported to be beneficial in neurodegenerative disorders. Actually, when I was just recently in Israel and Egypt, and in Israel I was at a conference, a neurodegenerative disease conference. I went to some of it, but I wasn't really there for it. And you know what? Nobody was talking about coenzyme Q10, I can tell you, in that conference on the basic science of neurodegenerative diseases. And nobody's using it therapeutically in that. So they say, well, it might work in that disease. So what, you think cardiac arrest is like Parkinsonism? Or you think cardiac arrest is like ALS? What, are you crazy? But anyway, it might work for that. So therefore, we ought to use it after cardiac arrest. This is like Lazaroids. You know, everybody that's tried a drug to help with stroke, after the fact, to mop up all the bad, evil humors that go around, everything that's ever been tried has failed. They all work in experimental studies. You give a rat, throw some emboli up their middle cerebral artery, and give them all these different drugs, and they show less infarct size and better outcome, and then they all try them in humans, and they never work. But now they're saying they looked at multiple endpoints, and they suggest that it might work to do that. Okay, so let's do a good trial. So now you've heard all the stuff about therapeutic hypothermia, and, oh no, not yet, not yet. Okay, we still got some more to go, is how do you get them cold? That's the next issue. And there's a whole bunch of studies in here that look at giving them 30 cc's per kilo of ice-cold saline over 30 minutes. I think that's a pretty bold move. You have somebody whose heart just stopped, who probably has heart disease, and you're giving them whopping doses of fluids in order to make them cold, And so there's two things. One, it makes them cold, that's true, and they don't get in trouble. I mean, I've been dissing a lot of these other studies, but they don't seem to go into congestive heart failure and pulmonary edema, and they get cold. So I guess that actually does work. That's okay. This next group got 2,340 mLs over 50 minutes, and their CVP didn't go up. They put CVPs in these people. Where are these fluids going? I don't know if they run them into the bed to make them cold or what, but it seems to work. So that is one way that you can make them cold, and seems to be a way to do it if you want to do it. So what's my take on all this? I think we've been really premature to jump on the bandwagon and say we all ought to be doing it. Maybe it works, I don't know. If you want to do it, okay, that's fine. So it's at that level of evidence that I don't mind people saying, well, we think maybe it's going to work and we ought to try it. But I think to use this to drive policy, to have in New York City people to say, if your hospital doesn't do this, ambulances can't bring you cardiac arrest victims. At the level of public policy, you ought to have an awful lot better data than we've got now. Or to have a scoring system based on it, or to devote resources, and I know one hospital I'm affiliated with has one of these devices that can make you cold or make you warm, whichever you want to do with that, and spend tons of money on it. I think that's inappropriate. So how many here do therapeutic hypothermia and give it a try? And how do you do it? Iced saline, pack them in some ice and do all that kind of stuff? Okay, fine. I think part of it is we're now actually really working at doing something with that patient. How many here have to then work on them in the ER all the time and keep them around? No, see, I think it's the ticket to the ICU, and that may be actually beneficial for us. So that's fine if people want to do it. But I think I would hope somebody's going to do a really good randomized controlled trial of the way I've mentioned it for that. All right, how about massive PE as a cause for cardiac arrest? We all know that that probably happens sometimes. And what these studies show in here is that often those patients have pulseless electrical activity or nearly pulseless electrical activity. They have such a low blood pressure you can't feel them. You may see something with an echo. And so maybe these patients you ought to give lytics to. And so one of the studies in here is where they say, what's the use of doing a bedside ultrasound of their heart? Shows that there's maybe some activity, maybe the right ventricle's dilated because they've had a big PE. And they have one case here of a 25-year-old woman, and their conclusion is transthoracic echo can help with the diagnosis of massive PE and cardiac arrest. Well, what was wrong with the patient? It was a 25-year-old female who was on oral contraceptives who had chest pain and severe shortness of breath before she arrested. Do you really need the echo in that? I mean, how many other causes are there in that scenario that you can do it? So, it's fine if you have echo and that might help you, but I'm not sure this makes the case for it. There's one here, another one, Michael Blavis. I think he trained at Michigan because I knew this guy, and he does a lot of really high-end echo stuff. He's really good at doing this and using it for other reasons. And here he puts a TEE echo in somebody during cardiac arrest in 6 patients and said, we did it, we like it, we find things for that kind of stuff. So it might be one thing to think of how many here, if they think they've had a massive pulmonary embolism, they have enough history ahead of them going into it that they would try lytics in that? Yeah, I think it, actually to think it actually works fast enough is a little bit strange. I mean, when we give it to patients with MIs, it takes a little while until that artery opens up and the ST segments go away, and they're not actually perfusing much to get that blood to the clot, but I probably ought to try it then. Pericardial tamponade, can we look for this to save lives? And they make the case with pulseless electrical activity or low blood pressure, putting on the echo. Sometimes you see them with a tamponade, and that might work. And I've relabeled this from we did it, we liked it, to IJD, meaning it's just dandy. Okay, I like that kind of literature because it tells you people are kind of pushing the envelope, and maybe you should too. One of the other things about cardiac arrest, if you get them back immediately and they don't wake up, what sometimes has been the cause of that, and they have big-time EKG changes. Subarachnoid hemorrhage will do that. So that there was nothing wrong with their heart to begin with, so of course they came back. They have big-time EKG changes, and you think, wow, they must have had an MI, And then should you give them lytics, or should you do a CAT scan on these people looking for other things? This is one of the only studies I've seen where they did a lot of CAT scans. They did it at the discretion of the physician. So there was some reason they think that maybe something's going on in the brain and we ought to get a CAT scan. And so they did, and they found a lot of stuff, including a foreign body. How did that get there? Like, they didn't see the gunshot wound part? I don't know. That was sort of funny. They did find a bunch of things, and they said we changed our treatment sometimes, but nobody survived in it. So I think it's one of those things, kind of think about it, but that's about it. Organ donation, this is just an opinion piece that says we really ought to have the opt-out as opposed to the opt-in order to get organs. So what you ought to have is, unless you've signed something that says, I do not want my organs donated, you should have them donated. That's this person's opinion. I actually agree with it, but I don't know where that's going. So that's it. That's my take on all that. Questions, comments? Anything else? Yeah?
That's just on the kind of post-resuscitation EKG. I mean, I just had a patient that looked like a big MI. All of a sudden, things change. You go from this wide, complex tombstones to, a different rhythm that has nothing to say. I should be giving thrombolytics. The story wasn't good for MI. It was a chronic respiratory person who went out without her O2 to go to see the dermatologist. I'm like, this is respiratory. It's just the EKG sometimes. I don't know what to make of those.
Yeah, I agree. The EKG changes. First of all, one of the reasons I don't have an objection to a lot of things in this group is it's so small. I don't think we're diverting resources by doing an occasional hypothermia case. That's fine. But yeah, I think the EKG changed a lot. Maybe they reperfused, and that's why they came back, and therefore you wouldn't give them that. But I think if they have the same criteria on their EKG as you would do for somebody if they came in awake, you ought to think about giving them lytics or a PCI, depending on what your availability is, because you really don't know how those people are going to do over how long it's going to take them to wake up. And I think the cardiologists have known that for a long time. They say, we hate to be aggressive with somebody who hasn't awakened yet, but they may. So, all right, that's it.